Hey, good evening. Quality of life care for your aging loved one. Thank you very much for joining us here, and a quick hello to our virtual audience following us on Facebook Live. My name is Pablo Villa. I'm assistant editor of El Paso Matters. We are an online news organization dedicated, or founded in 2019, dedicated to in-depth reporting and investigative journalism. At El Paso Matters, we aim to expand civic capacity in our region. We do that through informing and engaging with our community. And that's the reason we're all here tonight. I'd like to introduce our moderator for today. That would be Cindy Ramirez to my right here, to your left. Cindy is a longtime local journalist who was named editor of El Paso Matters earlier this year, and she's our boss. So, Cindy, I'll let you take it away.
Thank you. What a kind introduction, and thank you for the applause. Thank you, and thank you everybody for joining us here, and we hope that we have some people watching online if they were unable to come out and are enjoying this in the freshness of their refrigerated air home. I want to give a little bit of a background of how this event came to be, so if you'll indulge me for just a minute. This event grew out of a brainstorming session with our staff. The task at hand was to talk a little bit about things that were happening in our own lives. And the idea was that things that were happening in our lives were probably same things that people in our community were going through at the same time. We had a variety of topics that came up during that conversation, but the one that was something that was of importance across the board, across our demographics, across all of our staff, regardless of our age, of our gender, of our ethnicity, was caring for our aging loved ones. All of us had concerns about what we would do when the time came to take care of our parents, our grandparents. Some of us were already in that situation where we were having to provide that kind of care or find services for our aging loved ones. So it was natural for us to put this together. We called on some of our partners to work with us to make this event happen, and so here we are. So before we begin our conversation, I'd like to call up our Director of Business Development, Bill Pitchcolin, to come up and say a few words about those sponsors. Bill?
Thank you, Cindy. Thank you all for being here. This is a wonderful event. As Cindy mentioned, this subject touches just about everybody's lives. I get the privilege of thanking our sponsors for helping support this, so I'd like to do that for just a minute here. I want to thank Comfort Keepers. Thank you to the local owner, Deborah DeSantos, and the operations manager, Desiree Martinez. You may have met them out in the lobby. Desiree is with us today with her coworker, and they can answer any questions after this regarding the services that they provide. We want to thank Texas Tech Health. They provided this beautiful building for us to have this event at. I want to thank Dr. Andrea Tani, Danielle Urbina. Danielle's right there in the back. Daphne Griffin and Aaron Bracamontes. That's the team that we work with a lot. They're always very, very supportive of El Paso Matters and the health initiatives in the community and what we cover. I'd also like to thank Credible Coverage. They're out in the lobby too. Thank you to Chris Argote. He's one of our panelists that came all the way from Houston to be with us today. He's the owner and broker of Credible Coverage and one of our panelists, and he's here with his coworker, Yvette Lemus. She's the local agent with Credible Coverage, and they will be out in the lobby after this to, again, answer any questions that you might have about financial aspects of healthcare. These individuals and organizations, they help make this event possible. They help support us in our news coverage on health issues just like this, and for this, we're very, very grateful. You are helping this community with the good work that you are doing, so we appreciate that. Thank you very much, and Cindy's now going to introduce our panelists. Thank you all for being here.
Thank you, Bill. Our first panelist was also instrumental in helping us put this together, providing a lot of background about some of the types of topics that we should discuss, and helping kind of shape the discussion here today. So our first panelist is Yvette Lugo. She is the director of the Rio Grande Area Agency on Aging and was a licensed master social worker in Texas who has worked in social services since 1996. She's been with the Area Agency on Aging, say that 10 times fast, since 2002, moving her way up to director in 2008. Thank you. Our second panelist is relatively new to El Paso, 2 years, I believe he said. Panelist Dr. Manette Coley, a geriatric medicine specialist and director of geriatric medicine at the Hospitals of Providence Trans Mountain campus. Dr. Coley is also an assistant professor of internal medicine at the Paul L. Foster School of Medicine on this campus. And he's board certified in both internal medicine and geriatric medicine, which isn't very common, and we'll hear a little bit more about that as we talk about the need for geriatric care in the community. Thank you for being here with us. We also have Chris Argote, who's the founder and CEO of Credible Coverage, which is headquartered in Houston, as you heard Bill mention earlier. Chris served in the U.S. Army for 8 years before starting Credible Coverage, which specializes in helping families with Medicare and Marketplace coverage, as well as financial planning for retirement. Thank you for being with us today. Our very special guest panelist tonight is Sylvia Vargas. Sylvia is a bookkeeper and client of the Rio Grande Area Agency on Aging. And she has been kind enough to share her personal story with us tonight. You'll hear from her and where she and her family are in providing health care for her mother. So thank you for sharing your personal story. We look forward to hearing more from you. Thank you for being with us. So we'll begin our conversation. We want this to be very casual, very informal. So if at any time one of you panelists wants to chime in, please do so. But I'd like to start with you, Yvette. I wanted to see if you could give us a little bit of a brief overview of the types of services that your agency offers.
Thank you, and thank you for hosting this event. As was stated, it's a very important topic to us, obviously, because Area Agency on Aging, by way of the title of our organization, obviously we serve the needs of older adults. And you'll find area agencies on aging across the United States. We were founded out of the Older Americans Act, and so here in Texas, there are 28 of us that cover certain geographical regions. So our region covers 6 counties in this far west Texas part of the state, headquartered here in El Paso County. And so really our charge is just to try to help older adults remain as independent in the communities for as long as possible. There was a brochure as you came in, if you happen to pick that up, that just kind of goes over the basic information, services that we offer as an organization. And you'll find these typical types of organizations, area agencies on aging, will provide the same types of services. So it can be anything as simple as calling and asking a question because you're interested in finding out what resources, what services, maybe just how do I find and get direction to where I'm needing that kind of assistance, maybe for yourself, or obviously here tonight caring for an aging loved one. What I love about the organization is the requirements for us are very simple, is that you're 60 years of age and older and you physically reside in our service region, or that you're caring for someone who's 60 years and older and physically residing in the service region. So really it's about promoting that self-independence, trying to avoid premature institutionalization, not that we have anything against our long-term care facilities, but obviously I think if all of us were asked of this, where would we like to age in place and live the remainder of our lives, I think all would agree home is probably where we'd like to be. And so in that sense, we try to, again, connect to resources. There is some funding that we do have to be able to pay for some of those things. In the meantime, while we're working with your situation to help connect you to a long-term solution, there's also things like benefits counseling that we can, so similar to, I'm sure, what's going to be discussed with looking for sometimes it's just finding the right benefit that fits your needs best to help stabilize your situation. We also have caregiver support services through by means of education, training, because oftentimes we find if caregivers are just better educated or help to learn how they can better handle either their self-care or the care for their loved one, they can continue on for the long haul. Because, and I hadn't said this, but to our family caregivers, obviously those of us that have been, thank you. Thank you for the work you do, because oftentimes it's very thankless and no one says thank you sometimes. So thank you for the work that you're doing. Anything else that we can try to connect, if we don't have the answer, we'll definitely try to connect to those resources in the community.
Thank you very much. I know there's a lot that your agency do, and we'll talk a little bit more about some specific services as we move forward in the discussion. But I wanted to ask Dr. Coley, I think a question that a lot of people have is, what is geriatric medicine? And is there an age when people should consider geriatric care?
That's a question that I answer differently depending on who asks me that question. Geriatric medicine, just by the term geriatric medicine, geriatrics is typically meant for individuals above a certain age. But that age is not well defined. I know a lot of resources use 65, 60. How we like to think of it, at least in our field, is that individuals who require more attention and more care. So someone who's 55, struggling with a lot of things, would be appropriate for geriatric medicine as long as they have those issues that need time, attention, many times patience, and help navigating those issues. If you go by age, from a medicine standpoint, we usually use 65. From a surgical standpoint, we sometimes use 70. But then, similarly in maternity medicine, we use 35. So you might have heard the term geriatric pregnancies. So that term in itself is a little bland, if you ask me, depending on who asks me that question. How I like to think of it, honestly, is the difference between a typical medicine, internal medicine, family medicine, versus geriatric medicine is it's time when we start focusing on what the patient wants rather than what is advised. That's a simple way that I like to think of it, that what matters most to the patient. And
Can you repeat that one more time for the people in the back?
So how I like to think of it is what matters most to the patient. It's a shift of focus. For example, the cholesterol-lowering medications, statins, which are given to almost every heart disease patient out there. If that's causing muscle aches in an elderly patient, we really have to have a conversation. Do we really need it? Right? Is it giving you the true benefit that you need? Some simple stuff like that. And the focus needs to shift on what does the patient want? And is there a clear understanding of that?
Thank you for that. I know we have a lot of questions coming to you soon, too. Chris, we'll get into specifics also a little bit later, but could you give us a brief overview of the types of services that companies like yours offer and why they're important?
See, folks, retirement is becoming something that we didn't think we'd live to that point, to where people are living till today. We're reaching 80, 90 like nothing nowadays. And people fail to plan for those later days in life. And for one, they don't think they're going to get there. And that's very common, right? But in reality is everyone needs someone to kind of talk to about healthcare, about important things that are happening in your lives. I've noticed helping people out that family sometimes doesn't know how to get involved and how to help their parents or their loved ones. And sometimes the members just may be embarrassed to ask for help. And I see that a lot too. People are just scared to ask for help. It's kind of, demoralizing for some people. And I think lack of planning is definitely is not a smart way to go about it. The rising cost of healthcare has really led to the importance of retirement planning. And health and wealth are hand in hand in this, okay? If you really think about it, 80% of all the money you spend on healthcare in your entire life is going to happen after the age of 65. That is a pretty scary figure. Think about it. From the day you were born to 65, you only spend about 20% of what you actually spend on healthcare, if you're one of the normal fortunate ones, right? But that's where I really grew a passion in this space. I used to be an air traffic controller before this, and I used to deal with some very complicated things. And when I learned about how complicated Medicare, retirement, healthcare planning was, I just went all in. To me, this is not a sales position. This is something that you have to have a good heart to help people with. And not everyone likes to talk about this. That's really the scariest part. So you got to have someone you could trust, someone that is very compassionate, understands you, that cares about you. And if it isn't family, who is that person for you? So we try to be a credible advisor for people in that space. It is not easy to be an advisor for retirement. The entry, the barrier level, the learning curve, they make it really hard to be a good one. So in reality is, we want people to talk to someone because knowledge is power, okay? Every 12 months, healthcare pretty much changes. Rates, costs, right? And your needs too. So we help people navigate the retirement options, right? When it comes to Medicare conversations, who are you having those conversations with, right? Is it a family friend, a cousin, a neighbor, right? Who you talk to really matters, right? So Medicare planning is, of course, one of the backbones of what we do, and that's helping people turn 65, right? Some people get on there earlier than 65, and that's okay. We help them too. But healthcare is a really big problem, whether you're on the retirement side or on the younger side of it, under 65. There's a marketplace option for those people too, so we help them navigate. If they need healthcare, there's several options out there for people, and we help them choose the right option.
I think healthcare reform is certainly a whole other session in and of itself, that it requires a lot of a different approach to that. So working with what we have today is why we're here today, to have that conversation, to kind of get us started, at the very least to help connect all of you with some resources. I'm going to come back to Sylvia in just a little bit, because I want to skip you really quick to help Yvette kind of set up your story a little bit. But we talked a little bit about quality of life, so I wanted to see if, Yvette, if you might indulge us and talk to us a little bit about how you define that, or what is quality of life to you.
That's very subjective as well. I think, for most of us, again, as we said, we're not planning for aging, and we know that aging is not cheap. And if we think about, or we're not thinking about, having those difficult conversations, what is it that we want? How is it that we're going to think about when we age and when we get there? Having advanced directives prepared, things like that. But I think quality of life is very subjective. I mean, what is it that I would want? Where would I want to live? Where would I want to be? Who would I want to be in charge of my healthcare decisions? Things of that nature. And I know that sometimes we're thrown into this role of caring for aging parents or aging loved ones or a spouse sometimes, and we didn't have those hard conversations, Or ourselves, we find ourselves now dealing with health issues that a year ago perhaps we weren't dealing with. So I think it's just best to, we always say, do your part to age well, have the difficult conversations. And sometimes when you throw culture in, I know that happened with my grandmother, when I'd ask to have the advance directive signed and all of that, and she would say, you just want me to sign this because you want me to die. I was like, no, I really, the work that we do want to know, what do you want, so that I make sure that your wishes are known. So those are the things I think, thinking about having those conversations, telling children, having a spouse know what's best, or what I would want to have done, planning, saving, doing all those things. I think all of that adds to quality of life. And when we don't find that, then obviously then there's resources there to kind of pick up the pieces and hopefully try to help set you on the right path.
So Sylvia finds herself kind of in the middle of this as we speak. Sylvia, like many other El Pasoans, for a long time, I'll share a little bit of this story, and then I'll let you go from there. But she shared with me that, like many of us, for a very long time, had family Sundays where everybody goes to mom's house, and that was the case in Sylvia's family. But something happened about 8 months ago, give or take, in your family that changed all of that. Can you tell us a little bit about what happened?
Well, my mom is 89 now. In November of last year, she had a stroke. And it hit that her right side was paralyzed 100%. And we had already talked about, I was a medical, power of attorney. I have always been her medical power of attorney. So I had always asked her what was it that she wanted. So she's a do not resuscitate person, But telling family members, I'm second youngest of my family. There's 8 of us. And telling them what my mom's wishes are, it's very difficult, especially to the older siblings. And so we were used to always going, my nieces and nephews, the little ones, they're like, why do we have parties every weekend? It's like, it's not a party, but we all go to mom's, and do like a potluck or whatever, and we get together. But when my mom got sick, everything changed. Even I think our family structure had to change, because we have to, we're broken into like 2 groups, the older ones and us. So the younger ones, we have to take over. So it's 3 of us that we have to take over 100%. And I always did the night shift, because I also have a daughter that has cerebral palsy, so I have to take care of her in the daytime. And my brother, he works at the right here in UNMC who has a respiratory tech. So we have known, we're kind of involved into the medical stuff, but being there, it's different. It's totally different. We thought we had a very strong family structure. When, hit, it crumbled. I'll be honest, it crumbled, especially with the older ones. And I think we talked about it, that they didn't know what to do. And they expected the 3 younger ones to do everything. And then when we had to step back and say, you know what, we need help. Because, my mom could do everything, and then all of a sudden she couldn't anymore. So she needed help with everything, bathing, changing her, walking, feeding, all of that stuff. So it made a big difference. So the older ones, and then my mom's very stubborn, and I think our parents are very stubborn.
Many of us
that's
can
a
relate.
that's a personal opinion, but my mom's very prideful, very prideful. So that also had to be looked at, just because like my older sisters wouldn't want to do like the bathing stuff, because it was more, and so it was more left to us, the younger ones, to do that, until the ones that we were taking the load started getting sick, like, because we were doing a lot. I wasn't sleeping. I was like at my mom's and then going to go do my stuff and then going, and then my brother the same. And so we started getting sick, and when they started to have to start pulling the weight, everything rumbled. And we thought we had, but thank God to them that it brought light, and it brought a break into our lives. And that's when I was able to step back and like get well. And even though it was, I think it's 15 hours that once it's a maximum we can get, something like that. But those 15 hours was a miracle to us.
Sylvia, I'm going to ask you to explain a little bit about how that care came about, because you went to the Area Agency on Aging
Yes.
for help, and they recommended some programs, correct?
Yes.
Yes. Do you want to tell us a little bit about how that
Sure.
happened?
So typically, what we received information. I don't know if it was you who called in, or if you.
It
were
was through
someone.
the rehab center in Sierra.
So usually referrals. So it's either people call in themselves, social workers from the community. Sounds like a rehab social worker. Obviously sent a referral on behalf of the agency. Maybe you all had a conversation and shared, or they maybe noticed the family needs help here. And that's typical. I'm sure some of you can identify with what Sylvia was talking about, just that burnout, the tiredness, the lack of cooperation amongst everyone within the family. Typically, I'm glad to hear you had some help, but typically for us, we see that it's usually one person, and the family can be huge, and yet one person is the only one that kind of takes over and steps up, or is basically left to pick up the pieces, and it can get really difficult. So it's very hard to then admit sometimes, I need help. And so what you're describing about being sick, being tired, and that's, again, statistically showing our family caregivers are more likely to be sicker, more frail, and eventually, unfortunately, pass before their loved one, because obviously you're pouring all of your energy into caring for your loved one. So I'm so glad that Sylvia came to us. In this case, most oftentimes family caregivers, what we'll recommend is that they receive respite care. And that is just that, giving them a little break by replacing them temporarily, not fully, but temporarily, because in our mind, our caregiver support programs, through the funding we receive, is to give our family caregivers a temporary break, because our goal is to support them so that they can continue for the long haul. And I know for some of us, again, that's really, we don't know what that long haul means. That could be 5, 10, 15 years. But obviously family caregivers are saving our government billions of dollars, because the work is really on their shoulders and the back. But temporary care hopefully provides that little relief, which sounds like gave you an opportunity to recuperate, rest, get a little bit better, so you can jump back in the game. And so we'll assess the case. It's on a case-by-case basis, so we typically don't give a number of hours. It's going to usually entail what is the need of the loved one that's receiving the care. And we have contracts with home health agencies to then purchase that service of an in-home provider to provide that respite care. So that's what Sylvia was describing.
Thank you. Dr. Coley, in this case, it was something that happened suddenly. Your mom, Belen, had this medical emergency, and so everything changed there. But in other cases, we see our loved ones who are aging, getting weaker, who maybe have other illnesses that are not keeping them well. And so the tough question is, at what point do people reach out for help, either as the patient or as the family member of the aging person?
So, firstly, thank you for the conversation that just happened. It actually, it's always good for me to also hear these things again. One of the things that I always request is we need to shift our thought process from difficult conversations. We need to call them essential conversations. These are essential conversations. These are not meant to be difficult conversations. Over the last couple of decades, they've gotten that term, and hence people kind of shy away from those. But if we, hope is that in the next couple of decades we improve ourselves and start calling them essential conversations, so that they become a part of what needs to be done. To answer your question, when is it time? There's different levels of care. If you're asking me when is it time to go see a geriatric medicine specialist, right? I would say any time where you feel that the patient themselves is not feeling heard, or what they're most interested in is not happening. If the medication burden is too much, like they have 20 pills in their pill box and they don't feel they need all of them. If they feel their mobility is an issue which is not helping them and it's not being addressed. Because a typical doctor's visit will always talk about stuff like diabetes, hypertension, the core medicine issues. That's the difference coming to a geriatric medicine specialist. When you talk about hospice or end-of-life care, that one's defined as someone with a terminal medical illness or a medical illness which will, pertinently lead to a decline within the next 6 months. But the most important one, I think, of these is palliative care, which is grossly underutilized. And I feel, what's the best way to say when a patient's ready for palliative care? It is that if you ever think about your loved one or even anyone in the community, and you can honestly say to yourself that you would not be surprised if this, our loved one or this individual were to pass away in the next 12 months, they should have already been with palliative care. Again, a point to note between palliative care and hospice, and again, I like to make this very clear. Palliative care patients can get the full level of care with curative intent. What that means is a cancer patient on palliative care can get chemotherapy. A kidney disease patient on palliative care gets dialysis. We never take away treatment options to prolong life unless it's not what the patient wants. So depends on what it is that, what level of care we are talking about that's wanted. Depending on the situation, and sometimes it's a personal choice that might differ individual to individual.
Thank you for that. Definitely seeing the theme here about having difficult conversations and making them essential, and opening up those lines of communication. One of the areas that I think that is also hard for a lot of people to talk about is how are we going to pay for all this? And aside from knowing some of the services that are out there that are offered free or at lower costs or whatever the case might be, Chris, can you walk us a little bit through some of the other options and some of the questions that we should be asking ourselves about being financially prepared for some of these circumstances?
Thank you. Yes. So as I mentioned earlier, we're living a lot longer than normal, and that's a good thing. But we just have to plan for it a little bit, right? See, insurance and health, when it comes to healthcare and what insurance covers, when it comes to these scenarios, right? Someone that needs hospice care now and it's lasting longer than 30 days, or someone that needs home health care and it's lasting longer than you ever expected. Insurance has limitations on these kind of costs. So just speaking of the elderly, since we're on that topic here, on Medicare specifically, they're only going to cover 21 days of like a home health care scenario. After that, a member is exposed full cost of after 21 days of service. Now that's a very short-term deal, right? Who foresees they're only going to need 21 days? you know, and after that, it's a per day copay kind of thing, you know. So long-term care planning, we tend to start thinking about it too late, okay? It's advantageous and it's affordable in the 40s, 30s, 40s, and 50s, okay? As you reached 50, 60, and then you're aging, you're starting to realize, man, I possibly might need some longer care than what I need. I'm getting getting diagnosed with things I've never been diagnosed with. How do I handle these costs, you know? So you have to start early. You really, I even got to start early, right? Like I got to look at these things now. I'm 34 now, and these are things that I'm looking at now. And I'm a first generation person. No one's taught me how to do that, and I only learned how to plan for this by helping people and seeing cases on a daily basis of long-term care usage or not having long-term care. But in reality, I really like to piggyback on the idea of having hard conversations with people you care about. It's probably the best way you could show that you love them. You know, now you know, it's having a hard conversation is all about how the person accepts your message. And you know, if you're a nice person with a nice smile, a really compassionate person, it's easy to have a hard conversation with people like that, right? But it's, you know, if people are a little edgy, a little rough around the edges or something, and they're just not as happy to help you, and you got to have a hard conversation with someone like that about healthcare costs and everything, it's just not pleasant. You're probably not going to want to do it, and you probably won't plan for it because it's just not a pleasant experience, right? We all tend to go back to what's comfortable in our lives. That's what you know. And when things get uncomfortable, we always come back to what's comfortable. And it really comes down to talking to people that have the knowledge to have a hard conversations with. You know, planning for retirement, it's the earlier the better, obviously. But we're living a lot longer, so the earlier is a lot earlier than you think it is. Okay, and we encourage people to talk to. Knowledge is free, available online. You know, these are things that we could research. We could learn online, but there's also professionals out there. Some charge, some don't, you know, but who you talk to matters, you know. And as a first generation child helping my grandparents, I didn't know the answers. I had to research and learn through other people. And I can't imagine, you know, going through it myself, not knowing the answers to provide my own family. It's a really hard position to be in. So, you know, who you talk to matters, as I say, you know, so the earlier you start, the better it's going to be for you or your loved one. My heart goes out to all the power of attorneys out there, the caregivers that are taking care of these people. In Texas, there's two types of powers of attorneys. There's a medical side and a financial side, okay? If you're taking care of anyone you love, you definitely want to be involved on one of those sides and both if necessary, okay? Because as we age, we might not be able to make decisions and have these hard conversations at this point. So having someone making sure they can look out for you, they're not trying to harm you. I know it's a lot of legal responsibility assigning this, and a lot of people are scared of it, right? There's notaries, a lot of things, legal things involved. But I'll tell you right now, when I'm sitting down with someone that's asking for Medicare advice or just healthcare planning, a lot of people have very complicated information to share, and I know they're not going to understand it, right? So how do I put myself in a position to help someone and have them understand what's happening here? Sometimes I need to get a family involved. I need to speak to someone that could understand this complexity of the care that's going on. And I think that's, you know, we all should lean on someone when it comes to that, whether it's a spouse, a family member. I've noticed sometimes kids are not involved as much, and that's pretty scary. So
is that something that you would recommend, that this become like a family discussion when they come to you?
Correct. I like to get everyone involved because everyone has to understand what's happening, not just and why, right? Because one thing, if someone tells you to do something and you don't understand it, you don't feel comfortable doing it. You think there's a second motive behind it. You think he's just trying to earn a commission or something. But there's a lot, like, to start, there's not one approach to fixing a problem. There's not one plan that solves all problems. So that in itself is a reason to have a specific, tailored conversation to your specific needs.
I wanted to kind of piggyback off of that, because I think when you're talking about options and different solutions, I think maybe Yvette had something to add about along those lines.
Mentioning financial, obviously, you know, I think sometimes we're surprised at the cost of things, like we've said. I think we've seen clients that assume they're getting a Social Security check when they retire, assume that they're going to qualify for Medicaid. What's that? Medicare, Medicaid, same thing. Very big difference, you know. The things that are going to then qualify you, resources. I've heard that time and again, like, well, we've saved all this, you know, our lives, we've paid into the system, it's not fair. That's the system we live in. Unfortunately, there are services and resources that are set up for people who are under resources and income as a qualifying way to receive assistance. And that's just the system we're set up in, especially here in Texas. It's very different from our neighbor in New Mexico. Very different Medicaid systems because each state has its ability to set up that sort of assistance. And so I think some of those are the shocking conversations that we've had with clients. I've talked to teachers who've all their lives have worked and have committed funding to the teacher retirement system, assuming they were getting Medicare when they retired. And that's not the case. If your school district did not pay into Medicare, you don't get Medicare when you retire. You are on the teacher retirement system. So it's things like that about knowing what your resources are, how you're going to pay for that. If you can afford a long-term care insurance premium, that you check what those qualifying things are, because some may not pay for nursing home care. They'll pay for an in-home attendant through a home provider, but what if you need nursing home level care? So it's things like that that you have to think about when we start talking about and planning, which again, often most of us don't, right? And so when you reach that point, and like we've said, it's not, what do I qualify for? Sometimes some of us are not going to qualify for anything, and it's going to require out of pocket. And again, if you've not saved, you've not planned, what do you do? And there are other things, I mean, again, talk about another session that you could plan for. There are certain legal ways to get around those kinds of things, and it's not illegal. There's things like a ladybird deed, a transfer on death deed, that are going to help then manage those things where you might qualify for then long-term care assistance through Medicaid and such. But Medicare does not have a long-term care benefit. It covers your hospitalization and outpatient, right? But there's nothing in there that's going to. The 21 days of a home health, we're kind of playing that dance with that home health agency to see how much you can get out of that. But really, a long-term solution to providing that day-to-day care that you are providing as a caregiver does not come with a Medicare benefit. So things that our healthcare system could potentially improve on, but again, ways to finance are just, it's not a one-size-fits-all, and we have to plan. So Chris makes a very good point.
Thank you for that. I wanted to get back with Sylvia because I wanted to talk a little bit about how the Area Agency on Aging helped get you some assistance, but also you applied for another program that'll get you longer term care?
Well, they helped us. My mom, it's in my title for my house. So I also had to do the ladybird thing because if not, I would lose. No, my house would be compromised, let's put it like this. And then also, which I did not know. You know, I'm a single parent, so I put my mom has in case something happened to me, not knowing that on the other side of the coin, it could affect her. So we had to apply for Medicaid for her. She has a Medicare part of it, but now we have to apply for the Medicaid. And that's a different ball. It's very different and very hard at the same token because it's all these rules and regulations, tons of them that we never thought about it. And so they had helped a lot on that aspect because they're been guiding me through all the ways that they'll give me something and then they'll take us off of something and then we have to come back with the money. And it's difficult. But the main thing is communicating. There's no shame on asking questions. And knowing and asking, it's good. I mean, I thought I knew a lot of things. I had my daughter, she was born with CP, so I have dealt my whole life with the child part of it, never the adult, which is totally different. So, but I'm so grateful that they helped us with the guiding and because sometimes I would call Medicaid and I don't get an answer. I leave messages and messages and messages, and I think they already know me without knowing me. But that's what it is, and it's what it is. But if I have a question, so I would call them. Nidia was the one helping me, and she's like, "Oh no, she's in, but now you have to." So leaving messages, and money-wise, it does make a difference.
Yvette, can you clarify for us a little bit about the program that you mentioned about Ladybird?
Well, so a ladybird is a legal term for as kind of protecting assets. Obviously, that's the use of an attorney. But if I may just kind of elaborate a little on Sylvia's, she's a perfect example of what our perfect client is for us, in the sense of, obviously she came to us, we were able to connect her to respite care so she could, do that. In the meantime, though, our case managers are kind of working behind the scenes to look at what is it that you can qualify for, in this case her mother, right? We knew that mom could qualify for Medicaid in this sense, because the long-term care Medicaid is what's then providing that in-home provider that we were providing. Our services, unfortunately, we don't have enough money to go around. We cannot be a long-term solution. So we like to work the case to where, okay, we're helping you. We've given a little bit of stability, given Sylvia a break in this case, while our case managers, kind of like the swan. That's how I always tell them, you're like the swans, right? But underneath, you're pedaling as fast as you can to help these clients of ours. In this case, we found mom's going to qualify. Let's submit the application. It's always obviously with consent. So we do all the background information, gather all the data, get that application in to then hopefully then qualify her. In this case, mom did. And so now mom has a provider through the state of Texas with the Medicaid benefit for long-term care in the community.
And it's just the long term, not, she doesn't qualify for the Medicaid itself.
The full-blown medical Medicaid.
That's why I said Medicaid, it has a lot of
yes,
different categories.
So it's the long-term community care, Medicaid, that pays for that in-home provider.
Dr. Coley, as we kind of navigate all of this paperwork that we're being told awaits us, how does that play into the services or the care that you're able to provide? Do you feel like there's services that you aren't able to provide when some of that isn't strained out?
So yes, sometimes there are restrictions when it comes to these things, and Medicare and the benefits that a patient might have are many times a restricting factor for a physician also. Like, I would want all my patients to have these services available to them freely, but like it's been mentioned, it requires a lot of legwork. It requires a lot of leaving messages, trying to get the right people who are gonna help you. So even as a medical professional, it's frustrating trying to help the patients or the caregivers navigate this. The difference that I honestly feel that happens is not every medical provider is exposed to them as well. Like my field, we are palliative care would be, they can help navigate you or at least get you connected with the right people, the right case managers or the right service lines to start those conversations, even if we are not able to do them ourselves. But these are definitely limiters even from a medical side.
And you mentioned the word frustration, which I think is probably also very common in trying to navigate all of this. Sylvia, I think at some point also you had mentioned about the stress that comes from being the caregiver and managing not just your loved one, but all of the paperwork. You also mentioned the word, I think, or not the word, but you had mentioned also that at some point you or some family member had also kind of fallen ill yourself because of the stress. Can you talk to us a little bit about that?
Yeah, I think I had managed stress because of Isabel. So I, with everything that happened and trying to deal with the system, trying to deal with my mom's sickness, trying to deal with family, especially my older sisters, that they have a different belief of stuff being done. The acceptance of understanding that it's okay for them to feel the way they are, because they were scared too. I mean, my older sister is only 15 years apart from my mom, so that makes a big difference. So they're like I guess. And they didn't felt that they could do that and expected us to carry the full load. And so I had to step back because I couldn't breathe. My SAT started dropping 280. I was not I have asthma, but never been that sick. So, it takes a toll. It takes a toll. And that's why, they came just on the right timing, because I'd had to ask my brother, and I was like, I have to step back. I have to step back because if I cannot breathe and I cannot take care of my mom, I cannot take care of my daughter, and I cannot take care of myself, what's going to happen?
You talked a little bit about family dynamics and how it impacted your family.
Yes.
You're a family of 8 siblings. Are you in a better place now? Have things changed? Have you been able to have conversations?
Oh, no, yeah. We after the fact we got the attendant. I mean, everybody went back and took a breather. You know, like it was like we all need to be stepped in. I mean, because we don't. My mom has never. Every time she's gotten sick, I mean, my mom's never been by herself at the hospital or anywhere else. So we have been always there for her, and so they also, I guess, had the time, the break in between, to see that we were tired, we needed help, and you know hard feelings. We have to understand that we all are different, and we all deal with the same. We don't deal with the emotions the same way. So stepping back and taking a breather, that's when they came in, and I'm so grateful for that, because really it allowed me to kind of like drop off, and take care of my health, and then so that my mom can come back. So
You got to take care of yourself first. I think.
Yes.
Dr. Coley would
Could I
agree,
ask you
so
how-
that you can provide care
Can I
for
ask
somebody
you
else.
how long did you wait before you asked for help? Because I think where there is no pain, there is no change in life, right? We always wait till it hurts. So
it was like,
how
yeah,
hard
I
or
couldn't.
how
It
long was
was
that
2
suffering?
months into the,
2 months into
that my mom had the stroke. It was after New Year's, so it was November, December, January, and that's when I was really, really sick, and I had to go, and I was using like 3 different nebulizers. I was using 3 different asthma things. I couldn't raise my SATs over 80. I was like out, and I was like, what's going on? But it was, I never thought I was gonna get, because of stress. And yeah, it took about 3 months.
So, Dr. Coley, how do we manage that as caregivers?
First thing is recognizing caregiver burden. That's the term we use, caregiver burden. If we are not knowledgeable about it, we're not going to recognize it. If we don't recognize it, we're not going to address it. It's as simple as that. I know we've brought up respite care during this conversation, which is again a wonderful thing, but not everyone qualifies. Sometimes respite care might just be in the form of different family members taking turns. It might look differently depending on the family dynamics. It might just be that, okay, nighttime you're in charge, daytime you're in charge, or when I go to work, you're going to stop by and stuff like that, or someone getting permission to work from home while their loved one is at home. So it looks differently depending on the individual situation, but if we don't recognize it, it's not going to be addressed. That's first. Second, like you were mentioning, it's very common that we notice that your own medical issues kind of flare up. Using 3 nebulizers, like you yourself mentioned, it happens all the time that suddenly the caregiver blood pressures are through the roof. Their diabetes management has gone completely disarrayed, sort of a thing. But the focus is on the more pressing issue, the loved one who is sick. Again, it comes out of good, it comes from a good place. You always want to help your loved one, your parent, your sibling, whatever the situation, but recognizing it is very important.
And with all of this comes, I think, also mental care, right, or mental health care. The person who is aging, who maybe feels frustrated or alone, depressed, lonely, all these different feelings also play into mental health. And then the family member or the person who is helping care for them is also feeling a lot of that stress and depression. Can you address a little bit about that, and how do we meet that challenge so that we're able to thrive and not fall further into a cycle of unhealthiness?
So depression amongst patients or individuals above the age of 65 is more common than you'd imagine. Like there's resources out there that say it's as common as 31%. So you can imagine 3 out of 10 individuals above the age of 65 having depression. That's a significant number. I'm just quoting one resource out there. You might find different numbers if you just Google it right now. Now, the worst part of it is it's not obvious at this age. What I mean by that is depression might mask itself and appear as dementia. Suddenly we'll say, oh, it's a process of aging, they're starting to forget more things, or they're getting lost while they're driving, or accidentally left the stove on, and we blame it on aging, dementia, cognitive issues, whereas the underlying problem was depression. It's easily missed, it's easily, diagnosed incorrectly and not addressed. At the same time, the medications we have to address it come with so many side effects that patients don't want to take them. So it's a vicious cycle which is very tough to deal with. Along with that, if you think of it from a very, philosophical view, why the depression, why the loneliness? Think of it like this. An individual made it till 65, independent, fully taking care of themselves, taking care of their loved ones as the elder person in the house. And suddenly they themselves might feel that losing grasp of their own capabilities. I know I used the word frustration in a different sense, but that can be frustrating for anyone. And on top of that, not being able to express that frustration can even be worse. They might not know what's happening to them.
Are there, I'll start with Yvette, but are there therapy services that are available to help deal with some of this?
I mean, yeah, we've got mental health providers in El Paso, Texas, just not always easy. I think there's still a stigma, unfortunately. I'm believing and willing and praying that it gets easier, and I think generationally we can hopefully start to see that getting better. We should be, hopefully, I don't have and I feel bad saying this, that we offer those services. I don't have the staff member right now that can connect with someone, but it can be as easily as just having the conversation. I think sometimes caregivers find themselves, or if we find support groups, hearing from a peer that it's okay that today I hate being my caregiver, my mother's caregiver, or today I hate caring for my husband. I didn't expect life to be this way. Oh, okay, I'm normal. I'm not a crazy daughter or a spouse to feel the way I'm feeling. So normalizing that with someone who's also feeling that same way can be therapeutic as well. And so those are the things that we would want to at least individually start with. But I think definitely, thank you, Dr. Coley, for making those points, because I think when we hear that it's okay, or these things that are happening to us or our loved ones, and I'm loving that you're recognizing the caregiver aspect, because I think too, if we've ever accompanied our loved one to the doctor, the focus is obviously on them, right? They're the ones that are ill, they're the ones that are sick. But I think physicians that are recognizing the value of a family caregiver that stops and says, how are you doing? How are your medical or health issues going, or you look a little off today, is everything okay with you? The fact that somebody actually recognized that I also am deserving of that respect and care too is so important, and that's where we get back to the self-care and the importance of that. Or I love that Sylvia said that, making it okay to ask for help, because I think sometimes too, caregiver guilt and asking for help is so overwhelming that we'll just deal with it. I'll just deal with it, I'll do it. Mom doesn't want anybody to come in anyway. My siblings don't care to help. You know what? I'll just deal with it myself. And you find yourself more and more just kind of slipping into those things, like the healthcare issues and the depression that's brought up. And so, yes, obviously we would recommend if someone is really feeling that way, and because I think unfortunately sometimes stress and burnout, and my fear then turns into then abuse and neglect of our loved one. And that's where we get into very scary terms of being a caregiver for our loved ones.
Chris, do you want to address briefly a little bit about some of the, whether it's Medicare or Marketplace or some of those, are there enough services that provide mental health care or just counseling, therapy, that kind of stuff in some of these programs?
That's a great question. So everyone on Medicare, original Medicare does cover one mental health and depression screening a year for people, okay? This includes things like psychotherapy, going to inpatient or outpatient mental health visits. So, but like everything, there's limitations, right? If you need more than the normal person and it wasn't planned for, then insurance exposes you to some of those costs. So these are things to look out for, right? I think mental health is the most important, single-handedly the most important thing in retirement. I talk to a lot of people every day, whether they're just turning 65 or they're turning 95. And I can tell you the biggest difference between everyone I talk to is their mental activity, right? I see some people at 65 that I I don't think we'll make it to the next year, right? And I look at their habits, and they're just not as active as other people. So if there's any tip I could give about mental health or depression, is definitely utilize your healthcare benefits to maximize all your therapies, your screenings, and even diagnosis. Maybe you have something you never thought of. Right? Stress comes in many forms, and you just never know how it's going to come to you. So learning what your options are in your health plan could take and make a huge difference in whether you caught it too early or you caught it too late, and whether you're here today or you're not. So mental health is very important. Thankfully, Marketplace and Medicare do participate and assist people with this, but with limitations, right? And hopefully that does get better. But as of right now, unless you're qualifying for Medicaid, those long-term services kind of come off the table and you become responsible for. And as she had mentioned, every state handles their own Medicaid restrictions, income thresholds, and all of that. In Texas, it's pretty strict. I think on average it's about $28,000 a year or less, and that gets you on Medicaid. There's about 3-4 different levels of it, so you might fall into one of those levels, and depending on how well it covers the services you need, that your doctor says you need. So it's really important to ask questions and ask your health plan. They have a really big way to help you out.
Dr. Coley, you got a comment?
I wanted to add something here. Mental health discussions can be, it can be from all the way from psychotherapy sessions to psychiatry visits. The restrictions that at least I've noticed are mostly for psychotherapy, mental health visits, or well visits. Not as much for psychiatry visits. They're often considered specialty visits, which if a primary or a geriatrician recommends, sends a referral to, it works. This is where having a strong relationship between the patient or the caregiver and the physician is important, and being able to talk about this is important. I'll give you a very simple example. Let's say someone is struggling with, depression, loneliness, grief, any of those. Their insurance situations, Medicare or Medicaid, does not cover regular psychotherapy sessions, right? They can cost upwards of $125, $150 a session, depending on who you're going to. We need to get away from the stigma about talking, about this with the provider or the physician who's the primary or the geriatrician. Because something we can always offer is, why don't you go see a psychiatrist? Why is this not being called a depressive disorder or something on those lines? You see a psychiatrist. A psychiatrist is more than capable of helping you with these issues, navigating these issues, and then those financial limitations don't come into play as much. But again, we're navigating the system to provide the best care possible, and it all comes into play if that conversation's actually had. If that conversation is not had, then nothing's going to happen. For example, what we notice all the time, I'll get a patient and suddenly they'll tell me, oh, by the way, I've been seeing this therapist for the last 6 months. I'm like, oh, that's great. Are you paying for it? Yes. Have you seen a psychiatrist? No. Why don't you go see the psychiatrist once? Go see, and all of a sudden, the psychiatrist puts a referral, and what they were paying $125 a visit suddenly vanishes. Right? So it's navigating the system properly, and we don't expect, I also don't know all the nuances of the system. I don't think, even if I practice for another 30 years, I'll know all the nuances of the system. I think it's just truly that's complicated, but if we don't talk about this, it's just not going to happen.
I wanted to, that untimely alarm on my phone was kind of a reminder that we are getting close to opening it up to questions from the audience. But I did want to do kind of a rapid fire with this conversation that keeps coming back to, have that hard discussion early. I want to ask each of you, you could really quick tell us if what you would recommend that we ask, whether it's our parents or our grandparents. What's the 1 or 2 questions that we as caretakers or possible future caretakers should ask of them? And I'll start with you, Sylvia. If you could go back, or if you have a situation, what's the one piece of advice, what's the one question that we should ask?
I think have better communication with my older siblings, to the way they could understand more what my mom wanted or wants, and following through. Because we all have a life, we all have our own families, but it's our choice. I chose to be part of my mom's care, and also it's my choice to be taking care of my family. But not to be forced that because I chose, you have to be there 100%. That we can all help each other and communicate with each other and be open with that communication. Just because life is life, and at least I'm talking about myself. I wanted to be there, and I want to be there for my mom. She's giving us so much that me being there didn't cost that much, except I still have my other life, my child and my other kids. And but yeah, communication, talk to each other and understand that, yeah, we all have different ways of loving and caring, and it's okay. But also have the freedom of, what, I need to step back, and for the other ones to accept that. I think that's very important.
Chris, what's the one question?
That's very well said. If I were to leave you with 2 questions here to ask people you care and love about going through hard times, whether it's on Medicare, Marketplace, of any age, right? See what they got, right? What is it that they need? What are their unique, special needs? Everyone in this room, we all take different medications. We see different doctors. We have different blood types. We have so many things that make us very uniquely special. So you want to list those specific needs, whether it's a brand of a medication, a brand of a service you use, a vendor, specific vendor, all of that. What is special about you? What do you need, right? So need, cost. What does it cost? What does this medication cost you? Because a lot of times, there's a lot of billing errors with insurance. A lot of times. And I can't tell you how many times I've had to call a pharmacist myself for a client to correct the copay that the person paid because they incorrectly verified someone's insurance. They overlooked it really quickly. There's just so many things that could go wrong. At the end of the day, pharmacists, doctors, all these Medicare professionals, they don't practice insurance, right? They practice medicine. And they can't focus on the insurance side. They have to be fully focused on medicine. So, that I think that plays a huge role. It's hard to talk to a doctor about cost if you don't bring it up. They do not know what is hurting you until you bring it up, right? And if anyone that's a parent, I'm about to be a parent, and I'll say, like, you have that parent instincts that when something's wrong, right? And I'm about to find out what that's like, but you just really got to go with your gut feeling. You got to ask people, what are they paying for what the services they're getting? And if it's changed, if it was $30 last month, why is it $140 this month?
It'll keep going up.
Yeah.
Let's move on to Dr. Coley. What is the one question that you would recommend that we ask?
I wouldn't frame it as a question. I would rather say that, at least when someone comes sees me in the clinic, my first question always to them is that, do you have an advanced will, like an advanced care directive or a will? And if they say no, I usually like to inquire why, any particular reason. 9 out of 10, the answer is, well, we've never thought about it. And it's more often than not just invoking that conversation. I try to explain to them that there's different aspects, financial and medical. From my standpoint, I'm interested in the medical. But if you're going to go through it, in a thorough way. And it starts with you being able to talk to within your own family to try to get this resolved while you're still able to make decisions for yourself, rather than someone else making decisions for you.
Thank you, Yvette.
Everyone stole my answers. I was like, yep, I was going to say, okay, I'll say that. No. But I think just building on that, the importance of it, obviously, I think, again, thinking about what we want when we are of that age, or perhaps when we can no longer make decisions for ourselves, knowing what those are, as I shared about having to try to get that out of my grandmother. I never did, because she never signed an advance directive or a directive to physician to tell us what she wanted. So we just kind of went on assumptions. And I think if you have that ability to make those decisions now, why not? Having the conversations, and again, based on times we've sat with families, sometimes saying, okay, I have designated your sister, your brother, as my power of attorney. So when it comes down to it, there's no surprise. We've had siblings that are upset, why did mom pick me? I don't know, but those are conversations, again, that can be had. And maybe it's just a matter of, well, I think she'll actually say no to a DNR and you probably won't. I don't know. But again, having the conversations in advance, that's why they're called advance directives. If you can plan and save and pay for a long-term care insurance plan, wonderful. If you put all the documents in place, like a transfer on death deed, so that there's no fear at that point, yes, qualified me for everything that I can get because I want to remain in my home, whatever that means, or I've already picked the nursing home or the foster home because I'm not going to burden anyone. All of those things that if you have the ability to do those things, then what a blessing. Otherwise, it may just come down to someone else making those decisions for you.
I think the answer to that question is why me is because I'm the favorite. I think this is a good place for us to turn to questions from our audience. If any of you have any questions of these experts out here or just have a story to share, please raise your hand and one of our staff members will come and so that we can hear you. Does anybody have any questions? I think the question is, what is ladybird referred to?
It's a ladybird deed. It's a form of that an attorney prepares for you that basically uses to, I don't want to say the word hide, that's inappropriate. Assets are protected, excuse me, thank you, to then help qualify for certain Medicaid funded programs, because there's an asset limit and there's an income limit on certain Medicaid programs that you might qualify for, especially the long-term care Medicaid that would help pay for those in-home providers or nursing home care. And so a ladybird deed, again, needs the use and services of an attorney to be then to be prepared properly to then qualify all of those assets listing. It's almost like a trust, where you're putting things away so that they don't affect your income and resource limit to then qualify for Medicaid. There's certain elder law care attorneys here in town that can prepare those for you.
Are there any agencies that do that for free or any services that do it for free?
No, it requires the services of an attorney. Mm-hmm.
I have actually had a little bit of good luck with the UTEP law offices, some pro bono cases. Just had a little good luck there. So, yeah, some of my patients have told me they've used their pro bono offices.
We'll put an
will say
asterisk
though
on
that
one.
I said ladybird deed there is something called the transfer on death deed, and that was specifically set up by our legislature, I think in 2015, for those people who don't necessarily have an estate. Typically it's just a home, sometimes, especially if you think about qualifying for Medicaid. But the transfer on death deed is something that you can do yourself. You have to sign in front of a notary. You have to then register that at our county clerk's office. But there is a form to prepare, although the caveat there is the person who is transferring the home has to be of sound mind to be able to make those decisions. So if somebody's already reached where there's maybe a question on capacity, maybe there's some mental health issues, or rather I should say memory-related disorders, that would then question whether this person is still capable of making those decisions. That person has to then be able to designate, my home will transfer upon my passing to this person. You do it in front of a notary, it's registered at the county clerk's office. So you basically, in essence, pay a fee. We are not experts in it, but the Texas Legal Services Center in Austin can provide assistance or guidance there. I know our Rio Grande Legal Aid office can do that, but that's something a little less, I don't want to say cheaper, more economical. Again, for people, when we think about our estates, we think about estates that's like, several homes, cars, stocks and bonds, et cetera, where then you have to then use the services of an attorney to then put all of that in order as it should be.
What was that called?
The transfer on death deed, or a TOD, T-O-D-D. So if you Google that here in Texas, the transfer on death deed. Again, Texas Legal Services Center in Austin. If you Google them as well, they have a whole section on that too. Can offer that form free of charge if you needed to speak to someone. The Texas Legal Services Center in Austin is set up specifically to help people who are 60 and older with that, or our local legal aid office, Texas Rio Grande Legal Aid, is also available. You have to make an appointment though, so it's not just kind of walk in like as a fee for service attorney, who then, again, elder law attorneys would be much more versed in the things that obviously happen as we age.
Yvette, you had an event coming up. Is that somewhere where some of these questions might also be answered? Can you tell us about that?
Thank you for that reminder. Yes, Area Agency on Aging is hosted, you might have seen or heard of it before, the Aging to Perfection Expo is something that we host at the Convention Center every year. This will be the 23rd year that we host that, and that is scheduled for September 11th this year at the Convention Center from 9 to 2. And we try our very best to have all of the resources that would assist older adults, family caregivers, baby boomers in planning and thinking about aging at that event. It's free of charge. So in the convention center itself, we have all of these booths. We average about 80 booths of information. There's health screenings, different information that would be offered. So yes, questions like that, or resources basically, is we're bringing that all under one location. While that's happening, we are simultaneously also having, educational sessions. So we've not solidified who we're having or what that, but I know that we are going to have our local county attorney's office present on the transfer on death deed, or the TOD, so that you can come and learn more information on that. I know that she's very good. Laura Christofferson often brings the forms with her so that you can see them yourself. And then just as a caveat again, because we want to showcase that aging and bust the myth of ageism, we have older adults on stage as our acts for the day, so that we can appreciate that aging does not have to mean that we are all ill and not still capable of aging well. And so we do that very purposeful, I invite all of you to then join us on September 11th to come to our Aging to Perfection Expo.
What time does that start?
9 a.m. So it's from 9 to 2, Wednesday, September 11th.
That's a date we can't forget, right? So, any questions from anybody else in the audience?
For Sylvia, thank you for sharing your personal story. But you mentioned respite care. Is that temporary?
Respite, yes.
Respite.
It's and it's for the break of the
caregiver.
Yes.
Yeah. Okay. Thank you.
Respite through our agency, yes, temporary help. Now that you've gotten the assistance and connection through the state of Texas, there is care, obviously, that you're never going to find 24-hour care covered by anyone, obviously, unless you're private paying to have someone. And so respite care is meant to be temporary. It's a temporary break in the sense of, our services, again, can't be long-term when we connect to the longer-term solution. So not only just the Health and Human Services, people may be veterans and not realize that they qualify for, there's something called aid and attendance through your VA benefits. There's also, we're blessed to have what's called the PACE program for all-inclusive care for the elderly. That's bien vivir. We have one here in El Paso. There's only 3 sites in Texas, so we actually have one here in El Paso. So if you're a participant, or there's a little bit different qualifiers for bien vivir, that's also an option. And then, of course, private pay. So you can access respite care, but if you think about it, it's a little bit of break for me, just to continue to kind of take a breather, do my thing. Respite care is meant to be a temporary, so that's kind of the thing. Sometimes people realize that maybe I don't want to be the caregiver, and that's a whole other conversation, and that's okay too. I think I have definitely seen that trend where people are deciding, I don't want to be the caregiver, but I will pay for someone to care for my aging loved one, and that's okay.
Could I add on to that? Because respite care is a caregiver's like immediate assistance and relief, and then there's other types of care that come with that. When you are on Medicare, you have something called skilled nursing care. That's the one I mentioned earlier that has only 21 days of a limitation. But the one that a caregiver really needs, okay, is something called custodial care. Okay, what is the difference between skilled nursing and custodial care, right? A skilled nursing care is a skilled licensed technician professional that comes to your house and is checking vitals, doing medically necessary checks that the company has the procedures for. Custodial care is that extra stuff in between, turning them on the bed, walking them to the shower, maybe preparing a meal, everything in between that a caregiver really suffers from, that would love a break from, is something called custodial care. And custodial care, unless you're on Medicaid, low income in Texas, is not covered by insurance. So that's something you want to look at, okay? Because that is a caregiver's best friend right there.
Which is similar. I mean, respite care will include that. Yeah. Those are the essential things. Yes, definitely skilled nursing is obviously that. There has to be a skilled need to do that. And that's kind of the game we play when we have qualify for home health services. that we have the skilled nursing coming in for physical therapy, occupational speech, things like that are qualified as skilled, and then sometimes they'll send in that attendant to do the bathing, the dressing, the feeding. Those are the exact custodial care types of things that somebody else would. It's not a skilled need, but they're definitely essential to helping someone remain independent in their home and offering that break to that caregiver.
There was a question back there.
Well, right now, my mom passed away in March, and my daughter has been taking care of my dad and her for the last, 5 years? And she's kind of given up on her college to take care of them because they helped me raise her. But is there a program that can, because everybody tells me, well, why doesn't she become their caregiver? And that's what I was looking at. Like, is there a program that can compensate her or anything like that?
This one's for you, Yvette.
That's a hard one. The workaround to that is obviously if your father qualified for the long-term care Medicaid that would pay for that in-home provider, in essence, then she would then have to become the provider of record or be hired by that home health agency that Health and Human Services then is paying in order for her to be compensated. But the way it's set up now, HHSC looks at things and they're saying, where is there a gap in service? So applying and saying, I need help, your dad, I need help, but I want my granddaughter to be my provider. That's obviously not, because that's not an unmet need. Your granddaughter is providing care for her grandfather. So it's more in that sense, not, the long and short of it is it's not a simple pathway to, yes, I can get paid because I'm caring for my grandpa. Now, if he's a veteran, there are caregiver services that will in fact pay for the caregiver who is taking care of that veteran. And it's a benefit that the veteran then decides, I receive a certain amount of money each month and I want to pay this person I'm choosing to be my provider. So I don't know if either of those might work, but the straight path to say, can I get paid because I'm taking care of my loved one? Not in Texas, and it's not a straight path, but there's definitely ways to kind of maneuver the system.
Is the best place to start to call your agency?
I would say so, yes. We can certainly have those conversations.
I actually have a couple of questions. Our situation is what you've been discussing. Because of a lack of planning, we are where we're at, and our first move was to see whether or not, a parent of ours would qualify for Medicaid, and we're being told that they don't. So we find ourselves in that situation where it's difficult for my mother's care because she's declining cognitively rather rapidly, so she's requiring more and more and more supervision and oversight. And physically, well, she's gradually going down, but it's more cognitive. So I've been interacting with the American Council of Aging, and much to my surprise, there are lots of different kinds of strategies that we can look into for my parents that didn't qualify for Medicaid, but just over the limit, so to speak. And so I'm understanding that there's different strategies. And so I have an appointment with a Medicaid planning professional on Friday, but I'm wondering, and my question is that advisable, or is it better to go through the AAA, and is there where we can get a consultation? Just, in other words, can we lay everything out on the table and let you know where we're at, and you can tell us what kinds of avenues or strategies we can pursue? Would that be a better deal?
I mean, obviously, I'm going to say yes. Come see us because that's what we're here for.
Mm-hmm.
Those are the kinds of questions and ways we try to navigate to help families. If we are not the experts, then obviously we're going to provide you with information or connect you to that resource that's best. I'm not sure who you're meeting with on Friday, but it sounds maybe similar to someone with a planning background. That perhaps would also have that. Those resources available. You are always welcome to call us. It sounds like maybe sitting with one of our benefits counselors might help to, and maybe meet with the person Friday and then use us as a second opinion. It's completely up to you. Obviously, our services are free. We're here to provide that support and guidance. And if we don't know the answer, we'll definitely try to get you to the person who does.
Can I also add, my mom didn't qualify for Medicaid. She qualified for the long-term though, because it's different. Because she's on Social Security and her pension, so she didn't qualify for the Medicaid part. But she did qualify for the attendant care. So
that's what I've been looking into is long-term care Medicaid.
So you have to apply. It's like I said, it's a lot of applications and a lot of. But that's how it works.
There's different form of in-home community care services division is who's then providing that. So there's family care, there's personal attendant services. There's different levels of the Medicaid that would provide that in-home support. If she were in a long-term care facility, there's nursing home Medicaid also. There's a different kind of, it's basically different pots of money that help pay for that may have varying levels of assistance. But we can certainly explore those options. And again, make that visit. If it's free, if you're meeting with them and they're not charging you a fee, see us if you feel like we need to bounce ideas off of. Absolutely.
I appreciate that. My second question is for Dr. Coley. My mom's under the care of a primary care physician, but we've been growing a little frustrated with the situation because, as I said, cognitively she's really declining rather rapidly. Our concern is that the other night she goes to bed at 6 o'clock and she was up till about 2:30 just standing and doing these repetitive things. And our concern is my gosh, if her sleep cycle gets turned, then what will we do? Who's going to stay and watch her? Because she's making decisions, or she's making irrational decisions, and it's very concerning. So our thought was we didn't know, we asked the doctor, could she prescribe something to help her sleep better? And we found a lot of resistance with that. So I started to think, do we go and ask for a psychiatric consult? But my question for you, I'm wondering if maybe it would be better to seek a geriatrician instead.
So, of course, I don't know all the particulars of your mom's case. What you're describing with the sudden decline and a rapid decline, the way you're describing it, by the time we start recognizing that or we notice that, it's usually too late, that patients don't qualify for many of the medications that might be given to them. What I mean by that is that most of the medications out there for these kind of issues are meant to be started in mild cases or early cases because the side effect profile is just too nasty that you don't want it in more advanced cases. So I get where you're coming from, but it's just there's no treatment out there which is outlined for this. Anything that's available for dementia-related care is meant for mild cases at worst. Okay. Now, the second part of it, the resistance, and again, hypothetically, I don't know the particulars, the resistance usually comes from the doctors because they're worried about the side effects. And depends on that relationship. If there's confidence or the provider feels confident that you guys will be able to manage those side effects, then they won't have a problem. But if it's reaching the point where the concern is harm to self or harm to others, yes, a psychiatric consultation is very warranted. It's very appropriate. Many times it's a 911 call to get them first to an emergency room and then into an inpatient psychiatric facility. Many times that needs to be done just to, again, open up avenues which were not open initially. Again, it's not easy. No one wants to go through that, but it's required. So if at any of this time harm is a concern, don't hesitate. You should be calling 911. Okay? And I'll give you very simple examples of harm to look out for. Wandering out onto the street, leaving the stove on, leaving the water running. Those are often the first precursors which are noticed. Any of those are happening, invoke these things. Don't wait for it to reach a point when something's bad's already happened.
Thank you very much for that. I think we have time for one more question.
Hi, so I'm thinking of the financial standpoint, Chris, so hopefully you can answer this. I've had several family members who have passed, and their entire savings went to their medical bills. So it seems to me like, don't get sick if you're not rich, right? So what kind of programs or advice do you offer so that we can better prepare for those, kinds of bills that are going to come? Because I don't want to leave, medical bills for my kids.
Yes. That is an amazing question. I get this a lot, and I'm going to recommend a couple products there. So with anything long-term, and what we're thinking long-term is you're thinking services that require maybe longer than 30 days of something, whether it's someone coming around for longer than 30 days. So long-term care is definitely a product I'm going to recommend. Now that's a difficult product because it has to be purchased early in life. And if we're past that point, it's honestly almost unaffordable if you try to consider this after 55 or something. It's off the table. So long-term care is a product that fills in the long-term needs, right? Now, if there's a low-income situation, there's going to be two big programs that help with these kind of situations. Obviously, we've been talking about one of them called Medicaid. Every state runs that one. And Social Security has a second program that, let's say they don't qualify for Medicaid. They might qualify for this other one called low-income subsidy that Social Security actually administers and runs this program. Some people qualify for LIS, but not Medicaid, and vice versa. It's a totally different program. So between these two things, if they're not helping you control the cost of your parents or your loved one's health care, there's also what we call, for lack of a better word, and just to keep it simple, I'm going to call it a gap filler. And they have these products that they give you benefits only when you use them, okay? They come in the forms of the name indemnity. So when this happens, right? When you go to the hospital, this check is released. When you use this specific service, this check is released for a specific reason. So it's like a just-in-case kind of thing where you could patch as many holes as you can. But I really think it's impossible to patch every single hole with healthcare planning. There's going to be some sort of exposure along the way between how original Medicare works and grabbing a secondary private company that fills in the gaps for you. There's always an exposure somewhere. But the best that we could do is start early between a long-term care product, doing a proper needs analysis to see which area needs a reinforcer or something that could make it run smoother. There's specific standalone products that you could fill as a gap, right? And that's something I highly recommend. They're called ancillary products, okay? They really fill in the gaps for people when needed. So now, one thing about them, sometimes people don't qualify. They ask health questions. So if that's off the table, then it really gets harder and harder to start taking care of people based on their health history. Insurance is, they're looking at the risk up front. And if the risk is too big, then it might not be a helpful option because they might not be open to cover or open to approve a certain case. So, list out what it specifically is causing the biggest leakage, the biggest cost, and speak to a licensed professional that has dealt with that before, okay? Because every kind of healthcare planning, there's so many areas to it. And there's people that specialize in specific areas compared to just, giving advice generically. So I think on the long-term care side, you would benefit from having an in-depth conversation with someone that can do an in-depth analysis, analyze the needs, and recommend some options for you. And you could take the best approach, from there.
Chris,
that is
thank
a great
you for
question.
that. We're going to get one last comment from Yvette, if you'd like to kind of pony off of that, and then.
Sure. I mean, obviously, our benefits counselors are there as well. Again, there are companies, there's reputable companies, things that specialize people. I think it's important that, as Chris said, that you talk to someone who is credible, who is certified, and who knows their products. Yes, our benefits counselors are also certified through the state of Texas. It's just another option, as I recommended. Hey, use this as a second resource, referral, backup plan, whatever. We're there to help you, but there are also professionals in the community who are trusted as well. And so there's people who are truly dedicated, and I'm sure we both have stories that we know of people who maybe aren't so credible, or maybe just looking out for their own pockets when they're talking about products to recommend and provide. But certainly there's resources. And again, if we are not the experts in everything, I will say that up front. We will definitely try to connect you to those people who are.
I think we'll go ahead and wrap it up there. Thank you to our panelists for this wonderful and enlightening conversation. Some of our panelists and our sponsors have tables outside with some of the materials that could link you to some of these services. Please grab them on your way out. Before we go, I'd like to ask Pablo to come up for some closing remarks. But please know also that we'll continue to cover a lot of these issues at elpasomatters.org. Our healthcare reporter, Priscilla, is here. If she'll say hello. And she is will continue a lot of this coverage and hopefully bring you some more resources. Pablo?
Thank you, Cindy, and thank you to our audience for being here and being engaged and sharing your stories. These can be challenging topics, but hopefully, tonight will just be the continuation for you and your families to continue to thrive. So we're grateful for you all being here. To our panel, on behalf of El Paso Matters, thank you very much for sharing your time, your expertise. I think everything you said tonight really resonated with everybody, so we're very grateful for that. As a token of our appreciation, I think Bill is collecting some parting gifts for you. So we'll go ahead and bring those up really quick. And while Bill's doing that, we want to close by thanking our sponsors one more time. That includes Texas Tech Health El Paso, Comfort Keepers, and Credible Coverage. A round of applause for them real quick, please. And thank you also to representatives from each of those organizations who were out in the lobby giving out information. We appreciate them. We want to invite all of you to follow our coverage on this and other important issues that are facing our community at our website, elpasomatters.org. We're on the web, of course, and also on all the social media channels. We look forward to seeing you there. And if you haven't already, I think you got the opportunity to do this outside, but please sign up for our newsletter. It'll give you everything you need to know about issues like this and plenty else. QR code's there. You should have been able to do that outside if not. But otherwise, thank you very much for being here. There's plenty of snacks and waters to grab something on your way out. We appreciate your time. Thank you. Good night.